You walk into your doctor's office feeling fine. You're 72, maybe 75. Healthy, active, just there for a routine checkup. The responsible thing to do, but what if that routine visit quietly puts you on a path you never needed to be on? An hour later you're booked for more tests. A week later, a procedure. A month later, you're recovering from a complication from a problem you never actually had, and the trigger a routine medical test you didn't need for a condition that was never going to hurt you. This isn't rare. It happens thousands of times every year, and it happens most often to people over 70. Here's what almost no one explains clearly. Some medical tests don't just find disease, they create it by uncovering harmless changes, triggering fear, and launching a cascade of unnecessary procedures behind closed doors, buried deep in peer-reviewed journals. Researchers have quietly confirmed something disturbing. Several of the most common screening tests done just to be safe offer no benefit after age 70, and in some cases they significantly increase harm. One test on this list raises complication risk by up to 35%, even when you're perfectly healthy. Another shows zero survival benefit after 70, yet leads to treatments that permanently reduce quality of life. And the number one test we'll reveal today, it has sent healthy seniors to the emergency room, the collapsed lung, even when absolutely nothing was wrong. Now, let's be clear. This video is not personal medical advice, it's educational based. Unpublished research, real patient outcomes, and guidelines from major medical organizations. The goal isn't to fear medicine, it's to understand a hard truth. More testing doesn't always mean better care, especially after 70. Before we begin, tell us in the comments, have you or someone you love ever had a test that led to more stress than answers? Let's uncover the 5 routine tests that deserve a second look, starting with number 5. Number 5. Carotid artery ultrasound. The pitch sounds irresistible. We're going to check the arteries leading to your brain, catch any blockages early, prevent a stroke before it happens. Who wouldn't want that? The carotid artery ultrasound uses sound waves to visualize the 2 major arteries running up either side of your neck, the blood highways that deliver oxygen to your brain. The test is painless, non-invasive, and often offered at community health fairs or as part of stroke prevention packages. On paper, it seems like the smartest thing you could do, but here's where the story takes an unexpected turn. When this test is performed on people without any symptoms, no sudden weakness, no speech difficulties, no vision changes, it almost never finds something that matters. But it frequently finds something that looks concerning. Specifically, it finds plaque. Virtually everyone over 70 has some plaque buildup in their carotid arteries. It's a normal part of aging, like gray hair or wrinkles on the inside. Most of this plaque is stable, harmless, and will never cause a stroke. But once it shows up on a scan, everything changes. That finding goes into your medical record. It gets flagged. It creates worry, and suddenly, you're being referred for more tests, or worse, for procedures like carotid artery surgery or stenting. These are not minor interventions. Carotid surgery involves cutting open your neck and physically removing plaque from an artery that feeds your brain. Stenting involves threading a catheter through your blood vessels and implanting a metal scaffold inside the artery. Both procedures carry significant risks: heart attack, stroke, nerve damage, death. And here's the devastating irony: a landmark study published in JAMA Internal Medicine examined what happens when asymptomatic seniors receive carotid ultrasound screening. Out of every 1,000 people tested, only 3 had blockages severe enough to potentially benefit from intervention. Nearly 60 were referred for additional testing or procedures. Several actually suffered strokes as a direct complication of the interventions. Very procedure meant to prevent stroke caused stroke. The U.S. Preventive Services Task Force, the independent panel that evaluates screening tests, explicitly recommends against routine carotid ultrasound in people without symptoms. The evidence is clear: the risks of false positives and unnecessary procedures far outweigh the chance of preventing anything. But context matters. If someone experiences warning signs of a transient Ischemic attack, what's sometimes called a mini stroke, symptoms like sudden weakness on one side, difficulty speaking, or vision changes, then carotid ultrasound becomes valuable in that situation. It helps doctors plan treatment to prevent a major stroke. The test isn't bad. The test without symptoms is the problem, Elias. Learned this the hard way. Elias was 76, retired after a long career in plumbing. He felt great, healthy, strong at a community health fair. A friendly technician offered him a free carotid screening. Why not? It was free, it was easy, it seemed responsible. The scan showed moderate plaque buildup. His doctor, seeing the results, recommended a stenting procedure. Better safe than sorry. The doctor said during recovery from the stent placement, suffered a small stroke. It left him with slurred speech and weakness in his right arm, problems he still lives with today. A stroke caused by the treatment for a problem that was never going to cause a stroke. Elias often wonders what would have happened if he'd simply walked past that health fair booth. The better path? Blood pressure management, cholesterol control, a healthy diet, regular movement. These interventions reduce stroke risk more effectively than any scan, without the cascade of complications when symptoms appear. That's when testing saves lives before symptoms appear. Testing often just creates problems. But the next test on our list surprises almost everyone who hears about it. It seems so harmless, just a simple blood draw. Number 4. Routine vitamin D testing. It sounds like the most innocent test imaginable. A simple blood draw. Check your vitamin D level. Make sure you have enough of the sunshine vitamin that supports bones, immunity, and brain function. What could possibly go wrong? Quite a lot, actually. In recent years, vitamin D has been elevated to almost mythical status. It's been marketed as a miracle nutrient, the answer to weak bones, frequent infections, fatigue, depression, and dozens of other complaints. Testing for it seems like common sense, especially for older adults who may not get enough sun exposure. But here's what the research actually shows for people over 70 who aren't experiencing specific symptoms of deficiency. Symptoms like bone pain, severe muscle weakness, or unexplained fractures. Routine vitamin D testing rarely changes anything meaningful. What it does do is create problems. A 2020 study published in the New England Journal of Medicine found that more than 40% of seniors who tested low on vitamin D had absolutely no clinical signs of deficiency. Their bones were fine. Their muscles worked normally. They felt perfectly healthy, yet most of them were placed on high-dose supplements, often for 0 to 10,000 international units daily, far exceeding what the body actually needs. The consequences were alarming among seniors taking high-dose vitamin D supplements. Kidney stone risk increased by 23%. Rates of hypercalcemia, dangerous calcium overload causing nausea, confusion, and heart rhythm problems, jumped by 18%. The treatment for a non-problem created actual problems. Here's what makes vitamin D testing particularly unreliable. Levels fluctuate constantly. They vary by season, lower in winter, higher in summer. They vary by hydration status. They vary by lab methodology. Someone could test deficient in January and normal in July without changing anything about their diet or sun exposure. These natural fluctuations get misinterpreted as problems, requiring intervention, launching a cascade of unnecessary treatment. And here's the bigger question: does vitamin D supplementation even prevent what we're worried about? A massive 2019 meta-analysis published in the Lancet reviewed over 80 randomized trials involving tens of thousands of participants. The conclusion was sobering. In seniors without symptoms or specific risk factors, vitamin D supplementation did not significantly reduce fractures or falls compared to placebo. The promised benefits weren't there, but there are situations where testing makes sense. If someone has diagnosed osteoporosis, a history of frequent falls, or specific symptoms like chronic muscle weakness or unexplained bone pain, then checking vitamin D is reasonable. It helps guide targeted treatment. The test isn't the problem. Routine testing in people without symptoms is the problem. Samira's story is a cautionary tale. Samira was 81, still living independently, still cooking her own meals, still walking to the market every morning, but she'd been feeling dizzy and tired lately. Her doctor ordered a vitamin D test. It showed a slight deficiency. The doctor prescribed mega doses, 50,000 units weekly. A week later, Samira was in the hospital. Severe nausea, confusion, dangerously elevated calcium levels. Turned out her dizziness had nothing to do with vitamin D. It was a side effect of her blood pressure medication, something a simple medication review would have caught. The vitamin D test didn't solve anything. It created a distraction that nearly caused a crisis. The smarter approach? Most seniors can benefit from a modest daily dose, 800 to 1.0 international units, without needing blood tests. This provides reasonable bone support without the risks of oversupplementation when symptoms warrant it, not as routine. Now get ready. Number 3 is one of the most debated and misunderstood tests in all of medicine, especially for older men. Number 3, PSA testing for men over 70. Few medical tests have generated more controversy than this one. The PSA test measures the level of prostate-specific antigen, a protein produced by the prostate gland, that walnut-sized organ sitting just below the bladder in men. Elevated PSA levels can sometimes indicate prostate cancer. Sounds straightforward, right? Catch cancer early, save lives. But the reality is far more complicated, especially for men over 70. Here's the first problem. PSA isn't specific to cancer. High PSA levels can result from many conditions that have nothing to do with cancer. Prostatitis, inflammation of the prostate, often from infection. Benign prostatic hyperplasia, BPH, the natural age-related enlargement that affects most older men. Recent sexual activity, bicycle riding, or even a digital rectal exam. A high number doesn't mean cancer. It often means nothing at all. But once that number is elevated, the machinery starts moving. Biopsies usually follow. These involve inserting needles through the rectum into the prostate, a procedure that's uncomfortable at best and carries real risks of infection and bleeding, especially in older adults. And here's where it gets truly complicated. When prostate cancer is found in men over 70, it's often a slow-growing type that would never have caused symptoms, never spread, and never shortened life. Many men die with prostate cancer, not from it, but once cancer is diagnosed, even slow-growing cancer that poses no threat, the psychological pressure to do something becomes overwhelming. Patients are often directed toward aggressive treatments, surgery, radiation, hormone therapy. These treatments frequently cause permanent side effects: incontinence, loss of bladder control, erectile dysfunction, loss of sexual function, fatigue, depression, and diminished quality of life. The research is sobering. Landmark study published in the New England Journal of Medicine in 2012 followed over 180 men for 11 years. The findings: routine PSA screening did not significantly reduce prostate cancer deaths in men over 70. It led to a 50% higher chance of being diagnosed with cancer that never needed to be found. It led to a 30% higher chance of undergoing treatment that reduced quality of life without extending it. Men were being harmed by finding cancers that were never going to hurt them. The U.S. Preventive Services Task Force now recommends against PSA screening in men over 70, not because they want to ignore cancer, but because the evidence shows that in this age group, the harms of unnecessary diagnosis outweigh the benefits. But symptoms change everything. If an older man develops difficulty urinating, blood in the urine, or unexplained bone pain, then testing makes sense at that point. The PSA test is part of a diagnostic process, not a fishing expedition. Ibrahim's story haunts everyone who hears it. Ibrahim was 74, a former baker who had built his small business from nothing. He felt completely healthy, but decided to get his PSA tested after a friend was diagnosed with prostate cancer. His result came back slightly elevated. Biopsy that followed revealed low-grade prostate cancer, the kind that, statistically, was almost certainly never going to cause him problems. But cancer is a terrifying word. His doctors recommended surgery. Ibrahim agreed after the operation. He lost bladder control. He struggled with depression. His relationship with his wife became strained. 5 years later, the cancer still hadn't progressed. It probably never would have. Ibrahim often says he wishes he'd never taken that test. He was healthy before. He was broken after by treatment for a disease that was never going to hurt him. The wiser path? For men over 70, be guided by symptoms and personal risk factors. Have honest conversations with your doctor about whether testing would actually change anything, or just create anxiety and potential harm. Pay close attention. Now number 2 seems completely harmless. A quick, painless test that takes just minutes, but it may trigger the most dangerous cascade of all. Number 2. Routine electrocardiograms, EKGs. The EKG is one of the simplest tests in medicine. Small electrodes attached to your skin. A machine that records the electrical activity of your heart. The entire procedure takes less than 10 minutes, causes zero discomfort, and produces a neat little printout that looks very official because it's so easy, so quick, so seemingly harmless. Many doctors include it as part of standard checkups, especially for seniors. But here's what most people never hear when used as a routine test in someone without symptoms, especially over age 70. An EKG can become the first domino in a very dangerous chain. Problem isn't the test itself. It's what happens with the results. Here's the reality of aging hearts. They show changes, almost always tiny variations in rhythm, minor electrical pattern shifts, slight structural adaptations from decades of beating. These changes are usually completely normal, the electrical equivalent of gray hair or laugh lines. They don't indicate disease. They don't predict heart attacks. They don't require treatment, but they show up on the EKG as abnormalities. And once something is labeled abnormal in a medical record, the machinery starts moving. Suddenly you're scheduled for a stress test, then an echocardiogram, then possibly a cardiac catheterization, an invasive procedure that involves threading a tube through an artery into your heart. Each step carries risks. Each step causes anxiety. Each step costs money. And at the end of this cascade, the answer is often, everything is fine, your heart is normal for your age. But by then, the damage may already be done. The research confirms this pattern. A major study published in JAMA Internal Medicine in 2018 examined 16,000 seniors who received routine EKGs without having any cardiac symptoms within 6 months. Over 10% underwent additional cardiac testing. More than 1 in 50 had a heart catheterization that turned out to be completely unnecessary. Those who had invasive procedures were 12% more likely to be hospitalized with complications. The routine test led to anything but routine consequences. When does an EKG make sense? When someone has actual symptoms, chest pain, shortness of breath, palpitations, fainting spells, unusual fatigue with exertion. In those situations, an EKG provides vital information that guides treatment. When someone is starting a new medication that might affect heart rhythm, an EKG provides a baseline. But for a healthy 75-year-old who feels fine and just wants a checkup, the evidence says the EKG is more likely to cause problems than prevent them. Isla's story breaks my heart to tell. Isla was 79, a retired English teacher who loved gardening and walked every morning. She felt strong. She had energy. She had no cardiac symptoms whatsoever. During a routine checkup, her doctor suggested an EKG just to be thorough. He said the results showed something called non-specific SAINT changes, a vague finding extremely common in older patients that usually means nothing. Her doctor grew concerned, ordered a treadmill stress test. The stress test was inconclusive, so Isla was sent for cardiac catheterization, the invasive procedure where a tube is threaded into the heart. During that procedure, Something went wrong. Isla experienced a brief heart attack caused by the intervention. Itself, she spent 2 weeks in the hospital, months recovering. She never quite regained her confidence about her heart, even though her heart was never the problem. All of it could have been avoided. Every step of that nightmare traced back to a routine test she never needed. The smarter approach? Skip the routine EKG if you're asymptomatic. Focus instead on the factors that actually predict heart health: blood pressure, cholesterol, blood sugar, physical activity, stress management when symptoms appear. Test immediately, but testing without symptoms often creates symptoms in the form of anxiety, procedures, and complications. And now we've arrived at number 1. This test seems so simple, so standard, so automatic that questioning it feels almost rebellious. But the evidence is overwhelming. For people over 70 without symptoms, it may be the most unnecessary and potentially harmful routine test of all. Number 1. Routine chest X-rays. It takes 30 seconds. Stand in front of the machine, hold your breath, click done. The routine chest X-ray has been part of annual physicals and pre-surgical evaluations for generations. It seems as natural as checking your blood pressure. A quick snapshot of your lungs and heart that might catch something early. What harm could possibly come from 30 seconds of imaging? The answer will shock you. Here's the problem with routine chest X-rays in healthy seniors. They find things, lots of things, almost none of which matter. The lungs of a 70, 75 or 80-year-old person are not pristine pink balloons. They've been breathing for 7 or 8 decades. They show evidence of that history. Old scars from childhood infections, tiny nodules that have been there for years, age-related changes in tissue density, evidence of the time you had pneumonia in 1987. None of these findings are dangerous. None of them require treatment. But on a chest X-ray, they all appear as shadows, spots, and opacities, and shadows create fear. Once something suspicious appears on a chest X-ray, the cascade begins. That blurry spot requires a CT scan for better visualization. The CT scan reveals a tiny nodule. The nodule requires a PET scan to assess metabolic activity. The PET scan is inconclusive. A biopsy is recommended, just to be safe. Lung biopsy involves inserting a needle through your chest wall into your lung tissue to extract cells for analysis. In seniors, this procedure carries significant risks: pneumothorax, collapsed lung from air leaking into the chest cavity, bleeding into the lung tissue, infection. For chest tubes, emergency hospitalization. The statistics are staggering. A 2021 study published in Annals of Internal Medicine examined outcomes in seniors over 70 who underwent lung biopsies for incidental findings discovered on routine imaging. The results: more than 35% experienced a complication. Many required emergency intervention or hospitalization. Over 85% of the biopsies revealed benign findings that required no treatment whatsoever. Let that sink in. 8 out of 10 seniors who went through the anxiety, the radiation, the needles, the potential lung collapse, all of it was for nothing. The findings were harmless. The U.S. Preventive Services Task Force does not recommend routine chest X-rays, not for cancer screening, not for general health evaluation, not as part of standard checkups. Lung cancer screening is only recommended for specific high-risk individuals, those with significant smoking histories, and even then, it's done with low-dose CT scans, not X-rays for everyone else. Routine chest X-rays offer no proven benefit and substantial potential harm. Mr. Kuros learned this in the worst possible way. Mr. Kuros was 80, a retired bank manager who had never smoked a single cigarette. He had no cough, no breathing problems, no symptoms of any kind. He was in remarkable shape for his age before a simple hernia repair surgery. The hospital ordered a routine chest X-ray standard protocol. They said the X-ray showed a small opacity in the upper lobe of his right lung. Panic ensued. More scans were ordered. A CT confirmed a tiny nodule, probably benign. But we should make sure. The pulmonologist recommended a biopsy, just to be safe. During the biopsy, Mr. Kuros's lung partially collapsed. He spent 4 days in the hospital with a tube in his chest, draining air that had leaked into spaces where it didn't belong. His hernia surgery was postponed indefinitely. His recovery took months. The nodule? A healed granuloma from a childhood infection, completely harmless. It had been there for 70 years, causing no problems, and would have continued causing no problems for the rest of his life. But the routine chest X-ray found it, and finding it nearly killed him. The wiser approach: reserve chest X-rays for people with actual symptoms. Persistent cough, unexplained shortness of breath, chest pain, unexplained weight loss, coughing up blood. In those situations, imaging provides crucial information that guides life-saving treatment, but as a routine test in healthy seniors, the X-ray is far more likely to find something harmless and launch a cascade of harm than to discover something meaningful when it comes to protecting health after 70. The answer isn't more radiation, it's smarter medicine. Conclusion: the power of asking why. There you have it, 5 tests that can become dangerous when performed routinely on people over 70 who feel fine. Carotid artery ultrasound finding harmless. Plaque that leads to risky surgeries. Routine vitamin D testing, creating over-supplementation problems where none existed. PSA testing, discovering cancers that would never cause harm but trigger harmful treatments. Routine EKGs labeling normal. Aging changes as abnormalities that require invasive workups. Routine chest X-rays, finding shadows that lead to biopsies. Collapsed lungs and emergency rooms. None of these tests are inherently evil. Each one saves lives in the right context, when symptoms are present, when disease is suspected, when the information will actually change treatment decisions. The problem is routine use. The problem is testing without symptoms. The problem is asking questions of your body that you're not prepared to handle the answers to. Here's the uncomfortable truth about modern medicine: more testing doesn't always mean better care. Sometimes it means more anxiety, more false alarms, more procedures, more complications, more months of your life spent in waiting rooms and recovery wards for problems that were never going to hurt. Youth system is built on a philosophy of early detection saves lives, and sometimes it does. But that philosophy doesn't account for the reality that detection can also create harm, especially in older bodies that are more vulnerable to the interventions that detection triggers. You have more power than you realize. You have the right to ask, why are we doing this test? You have the right to ask, what will we do differently based on the results? You have the right to ask, what are the risks of finding something incidental? And if the answers aren't satisfying, if the test is being done just to check or to be safe or because it's routine, you have the right to decline. That's not being irresponsible, that's being informed. Goal isn't to avoid all medical care. The goal is to receive care that helps rather than harms, to undergo tests that answer real questions rather than creating new ones, to spend your years in strength and peace rather than anxiety and recovery-informed choices lead to better outcomes, and better outcomes lead to more years. LIVED fully, not in hospitals, not in fear, but in the life you've built and the people you love now. We want to hear from you. Have you ever had a medical test that led to more stress than answers? Do you feel confident knowing which tests are truly necessary for your situation? Has anyone in your family experienced complications from a routine screening? Share your story in the comments below. We read every single response and engage with personalized insights. Your experience might be exactly what someone else needs to hear today. Thanks for watching. Here's to smarter medicine and longer, healthier lives.